Chapter 14, Depressive Disorders. There are a wide range of depressive disorders that all share common symptoms. Symptoms like sadness, emptiness, irritability, and all can have an impact on the person's ability to function and carry on with their day-to-day activities. These depressive disorders are characterized in many different ways. Everything from disruptive mood dysregulation disorder, persistent depressive disorder, previously dysthymia, premenstrual dysphoric disorder, substance/medication-induced depressive disorder, and depressive disorder due to another medical condition. In our first case study, Ch14 is brought to the hospital after a suicide attempt. His parents found him in his backyard wearing his favorite black jeans and black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He's just been admitted to your floor for 24-hour suicide observation. The first condition we'll discuss is disruptive mood dysregulation disorder. This is a condition often diagnosed in children ages 6 to 18, with the symptoms including constant and severe irritability and anger, temper tantrums out of proportion to the situation at least 3 times per week, and they exhibit symptoms in at least 2 settings: home, school, out with peers, and the management's usually some combination of medications and cognitive behavioral therapy. The next would be persistent depressive disorder, formerly known as dysthymia. Low-level depressed feelings through much of each day for the majority of their days. At least 2 years in adults or at least 1 year in children and adolescents. And they must have 2 or more of the following: decreased appetite or overeating, insomnia or hypersomnia, poor self-esteem, difficulty thinking, or hopelessness. The next would be premenstrual dysphoric disorder, and these symptoms cluster in the last week prior to the onset of the period. These include mood swings, irritability, depression, anxiety, feeling overwhelmed, and difficulty concentrating. The symptoms decrease significantly or disappear once the onset of menstruation. In other depressive disorders, first would be substance-induced depressive disorder. And in this case, a person does not experience depressive symptoms in the absence of a drug or alcohol use or in withdrawal. It's usually associated with the use of that substance. And then we also have depressive disorder associated with another medical condition. And this is usually going to be a major medical condition, something like a CVA, Parkinson's, Huntington's, Alzheimer's. And the depression can set in when dealing with this life-altering diagnosis. To be categorized as major depressive disorder, 5 or more of the following must be present within a 2-week period: weight and appetite changes, sleep disturbances, fatigue, worthlessness or guilt, loss of ability to concentrate, recurrent thoughts of death, or psychomotor agitation. Plus, at least one of the following symptoms must also either be depressed mood or a loss of interest in pleasure, anhedonia. Additionally, these symptoms must be present for a minimum of 2 weeks to 6 months. For chronic conditions lasting more than 2 years, recurrent episodes are common. Symptoms can cause distress or impaired function. Episodes not attributed to physiological effects in the absence of a manic or hypomanic episode. Depressive disorders are the leading cause of disability in the United States and can affect people across the lifespan, everything from children and adolescents to older adults, and often comes in combination with anxiety or some other comorbidity. Continuing with our case study, during intake, Jeff doesn't speak much, but his parents are able to list the following symptoms they have observed: weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, or even the online games he used to play with his friends. And he also reports constant sadness. And obviously, we're checking a lot of boxes for a depressive disorder here. In our first audience response question, Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends in his classes, which he used to like. This may be best described by the term inappetence, impotence, indolence, or anhedonia. And the answer here is D, anhedonia, meaning that lack or inability to feel pleasure. There are many biological risk factors for depression. Everything from genetics, biochemical imbalances, stressful life events, hormonal irregularities, inflammatory disorders, cognitive changes. Cognitive factors include theorists believe that people may acquire a psychological predisposition to depression due to early life experiences. Again, coming back to that nature versus nurture phenomenon that'll be present throughout this mental health course especially. And again, those experiences in childhood contribute to negative, illogical, and irrational thought processes that may remain dormant until they're activated in times of stress. Other risk factors for depressive disorder include female gender, adverse childhood experiences, stressful life events, and other disorders such as substance abuse, anxiety, and personality disorders. Also, chronic and disabling medical conditions can also greatly contribute to the condition. For our assessment, the first thing we want to be assessing is that risk of suicide. And again, it's going to come up so much. ATI, NCLEX. I know we talked about it a lot in tutoring last week as well, about the importance of the role that safety plays, and especially mental health component of nursing. Always assess that suicidal ideations. Ask if they have a plan. Ask if they are having thoughts of harming anyone else. And you really want to make sure we're asking them and we're assessing this closely. We're also going to have behavior affects such as anergia, lack of energy, depressed mood, emotionless, anxiety feelings, thoughts and perceptions, delusions or hallucinations even. And unfortunately, we also want to be assessing for chronic pain, as this can be a very common comorbidity. For self-assessment, patients with depression often reject the advice, encouragement, and understanding of the nurse and others. They often seem unresponsive to nursing interventions and resistant to change. If your assignment is to have a therapeutic interaction with your patient that will not talk or may feel like a failure, when this occurs, the nurse may experience feelings of frustration themselves. It can be very difficult to open up that rapport and treat and get these types of patients talking. Your best response: recognize unrealistic expectations for yourself and the patient. Identify feelings that originate with the patient and try to understand where they're coming from and empathize with the difficult situation they're in. For our next audience response question, which question would be a priority when assessing for symptoms of major depression? Would that be A, tell me about any special powers you believe you have? B, you look really sad. Have you ever thought of harming yourself? C, your family says you never stop. How much sleep do you get? And D, do you ever find that you don't remember where you've been or what you've done? And the answer there is going to be B again. Assessing for that suicidal ideations, assessing that danger, that is your top priority with all mental health conditions. For the nursing process, there's a lot of different nursing diagnoses we could include for the care of these patients. Everything from risk of suicide, that's always the priority. It's going to keep coming up again and again. Also things like chronic low self-esteem, imbalanced nutrition, constipation, disturbed sleep pattern, ineffective coping, or disabled family coping. For outcome classifications, we want to focus on the patient's strengths in helping them to recover. These treatment goals are always mutually developed. We want to talk to the patient and work with the patient to identify what their goals are and what they would prioritize as recovery in their treatment. For planning, we always want to gear our treatments during the patient's phases of depression. We don't want to work with the patient when they're at their lowest points of depression. We want to focus on their particular symptoms, find a good time for this patient to work, and again, working with that patient's own personal goals and what they would prioritize within their recovery. Implementation would occur in 3 phases. That would be the acute phase from 6 to 12 weeks, the continuation phase from 4 to 9 months, and finally the maintenance phase for 1 year and onwards. There would be a lot of routes and methods used, everything from counseling and communication, health teaching and health promotion, promotion of self-care activities, and also teamwork and safety. And when evaluating, again, we're tailoring these to each of the patient's unique presentations. Basic self-care, thought processes, self-esteem, and socialization. When communicating with these patients, use simple, concrete words. Give them time and allow them time to respond. Listen for covert messages. Ask about suicide plans and avoid platitudes. When the patient is silent, avoid direct questions and make observations to reinforce reality. And again, these situations are tailored to each unique patient. Each of them is going to go through depression and depressive disorders differently. Some will be able to manage it much easier than others. There's some that are going to take a lot of work to work through this. Also, make sure focusing on self-care, helping that patient to maintain the aspects of their daily life, and working on self-esteem and improving their social interactions can go a long way as well. When choosing an antidepressant, there's going to be a lot of antidepressants on the market: SSRIs, SNRIs, MAOIs. We want to choose this based on the symptom profile of the patient. Each patient's going to react differently to these medications. Choosing the side effects which would be least troublesome to the patient. Some are going to come along with sexual dysfunction and weight gain, which the patient would just refuse to take and be non-compliant once they leave. Also think of things like ease of administration, history of past responses to antidepressants, and the safety and medical considerations as well, as this could be a medication that they could overdose on. Are we giving them a weapon to take home with them? I know back when we talked in our psychiatric medications, there are so many different antidepressants on the market. It's going to really take a lot of work and fine tuning between the patient and their prescriber to find exactly which medication is working best for them, and also to tailor and titrate those doses. Especially start getting into SSRIs, serotonin syndrome, MAOIs, special dietary considerations. There can be a lot of things that go into what is going to be the most effective medication and treatment here. When choosing an antidepressant, SSRIs, or selective serotonin reuptake inhibitors, are going to be your most common. These are drugs like Celexa, Lexapro, or Prozac, and they're a first-line therapy, though they do come with that rare risk of serotonin syndrome. Another one that may be better tolerated would be serotonin norepinephrine reuptake inhibitors, or SNRIs, things like Cymbalta or Effexor. You also have tricyclic antidepressants like amitriptyline, or MAOIs such as Nardo. But remember, with that MAOIs, that special dietary considerations of avoiding tyramine. There are also a lot of newer antidepressants on the market. I can't stress enough just how many antidepressants there are on the market. It's a very serious problem in this country, and there's also so many different classifications and amount of medications out there. Make sure you're knowing the major classes. We've hit those a lot: your SSRIs, your SNRIs, MAOIs, tricyclics. Know your major ones, know a few of the major drugs within it, your most common one. There's other serotonin antagonist reuptake inhibitors. There's a million antidepressants on there. Growing into ATI and NCLEX, make sure you've got a good handle on your most common classes of medications. For our case study, Jeff was just diagnosed with major depressive disorder. Which medication is the healthcare provider most likely to start this patient on? Would that be SSRIs, SNRIs, tricyclics, or MAOIs? And again, that far and away most commonly prescribed is going to be an SSRI of some sort. Prozac, Zoloft, Paxil, Lexapro, Celexa. The list could go on and on. As far as alternative medicine or integrative medicine, one is St. John's wort. And this is an over-the-counter medication herbal supplement that some people report is very effective. They take St. John's wort every day, and after a few weeks, it does have some very benefits, much like a prescribed antidepressant would. This is also something we want to make sure we're assessing for, and we are documenting in their chart, including in their medrec, because it can also have some serious interactions with other psychiatric medications. Other strategies would be things like brain stimulation therapies like ECT, vagus nerve stimulation, or deep brain stimulation. Also, don't discount the benefits of light therapy and exercise. A little sunlight and exercise goes a long way. When planning for this patient's education, discuss side effects of SSRIs, watching for that serotonin syndrome. Realize that they may induce agitation, anxiety, sleep disturbances, tremors, sexual dysfunction, or tension headaches. The effects of SSRIs on sexual performance may be the most significant undesirable outcome for patients, especially for men. They may just refuse to take it altogether. For St. John's wort, this is that flower processed into tea or tablets. Tablets has been far and away the most commonly way I've seen. It's thought to increase serotonin, norepinephrine, and dopamine within the brain, and it's useful in mild to moderate depression. For electroconvulsive therapy, this is a very effective depression treatment, but it's also a last resort that's used in very, very severe cases. That psychotic illness is the most common indication. And it is a primary treatment, but it's used in the case of severe malnutrition, exhaustion, and dehydration due to the length of that depression. It's only in severe cases. It can be safer than medications with certain medical conditions. Again, it's going to be a very invasive procedure, but a lot of patients really swear by its effectiveness. For repetitive transcranial magnetic stimulation, this is not invasive. We're using MRI strength magnetic pulses to stimulate focal areas within the cerebral cortex. The presence of metal is a major contraindication, just like with any other MRI. And adverse reactions include headache and lightheadedness, no neurological deficits or memory problems, rarely can have seizures afterwards, and most are mild and include a scalp tingling and discomfort at the administration site. Then we have vagus nerve stimulation. Originally used to treat epilepsy, this can both decrease seizures and improve the mood. And this involves electrical stimulation to boost the level of neurotransmitters. Unfortunately, it can also have voice alterations, as they are placing a probe down the throat to stimulate that vagus nerve. It can also result in neck pain, cough, paresthesia, and dyspnea, which can decrease with time. And finally, deep brain stimulation. This is a surgically implanted electrode that's planted within the brain, and it stimulates regions identified as underactive in depression. It's much more invasive, and this is going to be another one that's used only as a very last resort. And light therapy. This is a first-line treatment for seasonal affective disorder. Its efficacy is due to the influence of light on melatonin. You might not get it as much down in Texas, but up here in the north, up here on the Great Lakes, it can be very dark and gray for several months a year, and it can really wear on people. I also spent several years in Alaska, up in Fairbanks, like right off the North Pole. And that lack of daylight for several months can be seriously jarring, be seriously wear on some people. And yeah, I was in the Army on base. They'd actually have a special office with light therapy where they would prescribe people a couple times a week. They'd have to come sit in this room of simulated sunlight and would go a long way in improving their mood, getting them out of that seasonal depressive disorder. Also, don't discount the benefits of exercise, both biological, social, and psychological effects. Increases the availability of serotonin and can go a long way in improving a patient's mood, just getting them up, getting them active, getting them moving. For our advanced practice interventions, yeah, that cognitive behavioral therapy is going to be that first line go-to for treatment, but it'd also be used in conjunction with time-limited focus psychotherapy, behavior therapy, and group therapy. For our last audience response questions, a patient with major depressive disorder walks and moves slowly. Which term should the nurse use to document this finding? Psychomotor retardation, psychomotor agitation, C, vegetative sign, or D, anhedonia. And in this case, it is going to be A, psychomotor retardation. For our last audience response question, which assessment finding in a patient with major depression represents a vegetative sign? Would that be A, restlessness, B, hypersomnia, C, feelings of guilt, or D, frequent crying? That answer here is going to be B, hypersomnia, or excessive sleeping, laying in bed. And again, that's all we have for this chapter. I'll see you on the next slides.